H's and T's, interesting question. They classically in ACLS enter into the train of thought in PEA and pulseless electronic activity, where it's not VT, it's not VF. They don't have a pulse, but you've got some rhythm on the monitor. But they're important for, I think, all types of rhythms, because they get at, what could we be missing that if we correct it, could improve our outcome, our ability to restore spontaneous circulation. And so, with VT, VF, which is the focus of this podcast, I would get to the H's and T's after several rounds, like, 5 rounds or so at the 10-minute mark. And I keep seeing a shockable rhythm. I keep delivering shocks and they're not getting in. I've got the right dose of epi. I've got access. I know it's going in and not responding. And so then, the big ones that you think about in our environment are going to be hypovolemia, right? Is this a traumatic scene? And, their blood volume could be so down that even with good circulation, there's just not enough blood in the tank to perfuse the heart. And do I need to get, some blood going? Acidosis is a big one. Is their pH so low that they're not responding to the epi? pH of less than 7.2, 7.1 for sure, they're not responding to the epi. And you don't necessarily need to have an iStat and run the lab. You just be like, hey, we've been at this for 10 minutes. They're not coming around. Let's try some bicarb. We're not going to hurt them, and it might help. 1 amp or 2 amps. I generally, in an emergency situation, would do more rather than less. I almost never give 1 amp. I'm always like, let's give 2, right? If I've got them, let's give 2. Because you want to kind of front load your auxiliary actions to be as effective as possible, as quickly as possible. Hypoxia is a big one. Get a pulse ox on their finger, and is their pulse ox 70? Well, what can we do about that? Can we give more effective mask ventilation? Do we need to switch to like 2 ventilators, one for a mask seal, get a better mask seal, or do we need a definitive airway? Probably not off the bat. Are you going to be like, let's put a tube in? But if you've been going for 10 minutes, 15 minutes, you're not successful, and the patient's pulse ox is 70, 80, and despite like a good mask seal and good rise and fall of the chest when you're giving this ventilations, you might want to think about that. That's going to be tough to do. Getting an airway in is tough to begin with. Getting an airway in while CPR is ongoing we do it, but, it's usually anesthesia and they're pretty good. And then probably the last thing is, some sort of tension physiology, right? Do you have a tension pneumothorax that is impeding the ability of the heart to expand and fill with blood and perfuse itself?
Like,